Hello, everybody. I am Francesc Bosch. I am head of Department of Hematology at the University Hospital Vall. And also, I have the privilege to chair the Spanish group of CLL. So CLL is my topic. The question today is the factors that influence the selection of BTKi inhibitors plus BCL-2 inhibitors in CLL. So nowadays we have many options for the treatment of our patients. We have a group of drugs that are given continuously. And also we have different fixed duration strategies that are based on the use of venetoclax, the BCL-2 inhibitor. So among the fixed duration therapies, these venetoclax combinations, we have, I would say, three possibilities now that are venetoclax plus obinutuzumab. We have venetoclax plus ibrutinib, and recently in Europe has been approved venetoclax plus acalabrutinib. So we have three different options. The last two sometimes are combined or are approved with the addition of anti-CD20 monoclonal antibody, but not in all the countries, at least in Europe. So all the algorithms that we have nowadays for the treatment in CLL are favoring the use of fixed duration therapies. Why is that? For many reasons. The first is the cost. We are saving resources for all the health systems. The second is the development of resistance, the continuous therapy pushing cells to develop resistant mutations. Therefore, if you limit the use of these drugs, you are saving the use of or the appearance of different mutations of resistance. And the third reason, the main reason, is toxicity. If you are giving a drug continuously, you are inducing long-term toxicity as opposed to the use of fixed duration therapy when you are sparing the use or the appearance of toxicities. So as I said, the most of the algorithms we are using in the Spanish group or the ESMO guidelines are favoring the use of fixed duration therapy. We have venetoclax obinutuzumab or BTKi inhibitors plus BCL-2 inhibitors. How can we choose that? We have different data on activity. These fixed duration therapies are very active. There is no comparison so far presented comparing venetoclax obinutuzumab against BTK inhibitor plus BCL-2 inhibitors. In the near future, we will have interesting data comparing both. So in terms of activity, it's difficult to choose between these two therapeutic strategies. So I think we have to use other factors that are dictating the strategy for our patients. Other factors are comorbidities of the patients. Other factors are the ease of the use of the drug, the distance from the hospital, the desires of the patients. So all these factors are in the combo, in the cocktail, helping us to decide the strategy. For instance, the use of obinutuzumab is somehow complicated in some hospitals, particularly in small hospitals, where they don't have experience for the management of infusion-related reactions, or the presence of cardiac comorbidities somehow preventing the use of BTK inhibitors in order to avoid serious cardiac comorbidities. Except for patients with high-risk genetics, where there is still the recommendation for continuous BTK inhibitor therapies, I would promote the use of fixed duration therapies in all other indications, and among them, venetoclax and obinutuzumab versus BTK inhibitor or BCL-2 inhibitors is difficult to choose, but I would say that this modern combination using the most important mode of actions, I would promote them for young patients with no cardiac comorbidities, which represent most of the half of the patients that we have to treat in CLL. For elderly population where BTK inhibitors can induce cardiac toxicity, I would go for other combinations like venetoclax or obinutuzumab. So in summary, go for fixed duration therapies. The use of BTK inhibitor plus BCL-2 inhibitor, in my opinion, should be proposed for the great majority of patients, particularly if they are young, without specific comorbidities, or if the patient living far away from the hospital where the management of obinutuzumab is somehow complicated. So thank you very much for listening us.